Jason, when one of your patients tells you they're taking ibuprofen, Tylenol, gabapentin, a muscle relaxer, and maybe an opioid, how confident are you that they actually know what these drugs are doing?
Extremely confident.
Wait, really?
No. But I say things confidently, which is almost the same thing.
Okay, excellent. That's why we brought in an actual expert today.
Yeah, because apparently take 2 Advil and see how you feel tomorrow is not a pharmacy degree.
Today we're talking to someone who knows considerably more about drugs than the 2 people on this side of the table. It's pharmacist Rob Linares, senior instructor at the School of Pharmacy at the Oregon State University.
Go Beavs. Yes, today we're talking about the drugs that our patients take before they come see us, which ones actually help, which ones just make you sleepy, and when does "I'm on a few medications" require a second sheet of paper. This is The Pitch. What happens when a chiropractor and a physical therapist get together to make a health and wellness podcast?
But chiropractors and physical therapists don't like each other.
Oh, think again.
I'm Dr. Kathy Lynch, physical therapist who likes to help people move and get stronger.
I'm Dr. Jason Young, an evidence-based chiropractor who uses humor just as much as adjustments to help people get better.
Welcome to the Pitch Podcast.
Remember, there's no I in pitch. Welcome back, everybody, to the Pitch Podcast. I'm Dr. Jason Young.
And I'm Dr. Kathy Lynch.
Yes, and we are still being allowed to release podcast episodes. Yes, the injunction has not gone through yet.
No, we've taken it back to the courts.
Yes, exactly. No restraining orders. No. So, hey, thanks to all our listeners. We're going to get to, we have a really good guest, one that I'm super excited for today. Real quick, let's handle a little bit of show business. Not show business, but business about the show.
Yes.
So, man, I'll tell you what, Kathy. So in the last one, when I talked about how Spotify had popped up that thing about like, hey, a show like yours should have way more listeners. Clearly that worked. Yes. We were at 140 subscribers on Spotify. Yes. And since I said that, we're now at 141. So
boom.
Yeah, we're killing it.
Nailed it.
Yes. This is an awesome podcast. I'm sure both of you agree. So, yeah. No, but that's just a reminder. You should subscribe to this because that helps us. It helps you, and it might help somebody else.
Yes.
We don't know who, but it would be great. So subscribe, send episodes that you think would be helpful to a friend. I think that this is a really great Christmas gift too. You can give the gift of a subscription to the Pitch Podcast.
It's
right. Free. I don't know. You just put a QR code on a piece of paper, stick it in their stocking.
Yeah.
Yeah. Birthdays, bar mitzvahs,
slide it across the table.
Yes. There you go. This is for you. Anyway, let's get to our guest.
Yeah. This episode I think is really going to be helpful for a lot of people.
Oh yeah. I'm excited about this because this is something that I talk with patients a lot about. So
yeah.
Yes. So who we got?
We got our good friend and expert pharmacist here.
Expert pharmacist.
Roberto, who his friends call Rob.
Yes. Can we call you Rob?
Yes, Rob's fine.
Yes.
Okay, we're in.
And Rob is a fellow nerd.
He is not. He got his degree before.
Oh, really?
The nards were given out.
Oh, sweet.
He's full of BS.
Oh, nice. Okay. Well, but another thing that's important about Rob is he is not the first person in his family that's been on this show.
That's right. All in the family.
Yes. Who's your spouse?
Terry Garcia Linares.
That's right.
Yes.
Have you ever had other family members on the show?
You guys are it.
I think just my family members.
Oh,
because
that's right.
Sometimes we get real hard up for guests, and it's like, I don't know. How many kids you got, Jason?
Griff's dying to be on the show.
He is. And, he listened to an episode where I mentioned we'll find a way, and he's taking that to the bank. He had the episode notarized somehow. I don't even know. How do you notarize a podcast episode? So one day we'll get him on. But yeah, Terry, I mentioned that you were coming on, and she she's competitive.
Oh, yes.
Yes, she is. And so she was like, I'm going to win. And I was like, I don't know how you win. She's like, yeah, his is not going to be better. So.
Yeah, when we play golf and I have a great drive, she'll have a better drive whenever I have a good drive. So she is better when she gets competitive.
That's right.
It's good. We're talking about the same person.
That's right.
Verified.
And Rob is just so supportive
Absolutely.
of her, too.
Yeah, but I'm really pulling for you here. So, yeah, I'm sure you're going to do great.
Yeah, so like we said in the open, Rob is a senior instructor, level 2 at the university at Oregon State University in the School of Pharmacy, and has won like favorite professor like 19 times in a row.
Oh, that's all?
Not that many, but a couple of times.
How many though?
I don't know. A few times.
Okay, he's being humble, but I know it's like 4 or 5 times in a row. So
excellent. Yeah. So is it safe to say you know your stuff?
I'm a community pharmacist, so so there's lots of different types of pharmacy. Just like I'm sure you guys' profession, people specialize in different things. So
yeah,
as
we
far
only
as
got one type of chiropractor.
Yeah. Well, people focus on different things. So, so as far as community pharmacy goes, I think I'm pretty knowledgeable. Plus, what I teach at the College of Pharmacy is pharmacy practice. Okay. Focusing on over-the-counter drugs. Yeah. So I'm relearning that every year for my class. So I'm pretty comfortable at it in that area. If you ask me to work in a hospital or talk about drugs they use in the hospital, I'll be like, I'm not sure. Okay. Right, so.
We're going to have to rewrite the alphabet real quick. Yeah. Just get rid of everything.
Start over. Yeah. So he's still a practicing pharmacist, and he has been so for 35 years.
Holy smokes.
Yeah.
And community pharmacist sounds like the friendliest type of pharmacist there is. Yeah.
Yeah. Well, community pharmacy, I think why, so when I was a student, and like students nowadays, they get exposed to a lot of different areas during rotations, right? You have to rotate many different practice sites. I think what attracted me to community pharmacy especially was that you do get to interact directly with patients a lot, right? So if you work, for example, in a health system, in a pharmacy, in a hospital, you interact with a lot of other providers, which is people really like that part. Yeah. But you may not interact directly with patients. And if you work, for example, in a hospital, you probably don't want to see patients again. Yeah. That's not a good sign.
Yeah, right.
But in community pharmacy,
again.
Yeah. In community pharmacy, I really enjoyed the aspect of, when I worked all the time anyway in community pharmacy, of seeing people over and over again, seeing kids grow up, right? And just getting to know people over time and helping them, right? Kind of helping with their health conditions and really, in a sense, keeping them out of the hospital in a way. Yes. So that's what I liked about community pharmacy.
Yeah.
Awesome. Well, Rob, I've been doing a lot of drugs lately, like a lot, like more than I've ever done in my life. All like above the board, right? But yeah, it's like, I guess the older you get, the more health stuff you got going on. But I really, really value my interactions with my pharmacists. And I think sometimes though, you know, people maybe look at their pharmacist and they're like, it's just this guy is the barrier between me and getting the drugs I need and then getting out of here. But I find my pharmacist to be really, really helpful, and so I'm excited to talk to you today, especially because I have some things that I tell my patients in terms of, here's how a pharmacist might be able to help you with what you have going on, and I just want to see if that's all BS that I'm doing. So yeah.
Well, I actually do the same thing as far as physical therapy and chiropractor. When I know a patient comes in for medicines because they were in an accident or something, I always ask them, are you following up with therapy or seeing a chiropractor? Because that is such an important part of the healing process. And medicines can be a part of that, right? And just to make sure that they can do those things.
Yeah, appreciate that.
Do you want to ask your question you ask every guest that we have on?
Oh, well, like, did you become a pharmacist because you couldn't get into chiropractic school, or? It's challenging. I mean, the acceptance rate is about 101%.
No, actually, well, you know the reason a lot of people become pharmacists is because they don't want to touch patients.
Oh, right? Okay, yeah, there we go.
So they want a healthcare profession where they're not actually that close to the patient.
It's like, people, take these pills.
Oh my God, I literally just yesterday saw a meme where on Instagram, or a little video, and it was like, pharmacist in an emergency and there's a person lying on the floor and the pharmacist comes in and it's like, oh my gosh, and grabs a bottle of pills and throws the pills.
Yeah. Just get a syringe.
That's how close.
Oh man. Well, so a lot of people, I've learned some things about pharmacists that I didn't really understand before, but the scope of practice is a little broader than I had assumed. Pharmacists can do things like give vaccine shots and take vitals and all that kind of stuff. So educate us a little bit about what does a pharmacist do besides just, the obvious, if you take too many of these, you'll poop yourself.
Yeah. So like I said earlier, there's a lot of different practice sites for pharmacists. Community pharmacy, which is what I'm most familiar with, that alone has a lot of things a pharmacist can do. So now in all 50 states, pharmacists can give immunizations or vaccines. When I graduated, we weren't allowed to do that. It was a few years after I graduated that Oregon allowed pharmacists to get certified to give vaccinations, and now it's spread across the country. And I think just to bring up COVID, because it's a good example of an epidemic like that was vaccine treatable or preventable, was a crucial sign that how important pharmacies are with that type of thing, because pharmacies are in many, many communities in rural areas and are often very trusted.
Yeah.
So for something like that there was some mistrust and things, people would trust their pharmacists, right? If they recommended a vaccine and they could access their pharmacy. So there was a lot of benefits to that. Your question, though, about other things, Oregon specifically has a formulary that they've developed over the last few years, the Board of Pharmacies developed over the last few years. And pharmacists can prescribe certain things based off this formulary based on protocols, which I think a lot of people may not know.
Right.
Probably the biggest one that the training program was developed at Oregon State College of Pharmacy was to prescribe oral contraceptives.
Yeah.
You could just walk into your pharmacy and talk to the pharmacist, and they can go through some questions and kind of assessment and prescribe oral contraceptives. And that actually came from a legislator in Oregon who wanted that to happen, and then they came to the college and the Board of Pharmacy and said, how do you guys make this happen? And we did. And from that, it came many other things. And now, so there's a whole formulary of lists of things that pharmacists can prescribe or authorize, I guess. Probably the most recent ones, like HIV, PEP and PrEP, like the post-exposure prophylaxis and pre-exposure prophylaxis. And there's some inhalers, insulin. That's kind of under what they call continuation of therapy. So if you're on insulin and you ran out and you can't get a hold of your doctor, a pharmacist could continue that therapy based on these protocols. And there's a few other things. Actually, the most recent one the board just approved was for opioid use disorder. And so there's some things. So really,
you're talking like Narcan or
Narcan's been on there for a while, and that's actually like the easiest because they want everybody pretty much to have that available. But buprenorphine, when people are addicted to opioids and they're trying to get off, that's a medicine to kind of help manage that. But not all pharmacies do that if they're comfortable kind of going down that road. But it is allowed in Oregon for pharmacists in community settings to do that, mostly to increase access. Because a lot of those things where you really need them right away. And if you don't have a provider, you have easy access to going to your pharmacy. It was a good option. But many other, pharmacists in other settings, if you work, for example, like at Samaritan here in Corvallis, pharmacists run pretty much manage the anticoagulation. So if you're on an anticoagulant like warfarin, that's pretty much managed by the pharmacist, right?
Really?
And which makes sense. It's a drug. They monitor it. The physician has to oversee it and authorize things, but the pharmacists pretty much say, well, based on this, you go in and you see the pharmacist, they do the blood test, they make recommendations on the doses. So that's pretty much all managed by a pharmacist.
Well, and it's interesting because a pharmacist is a healthcare provider that you don't need an appointment to see. And you don't really get that anywhere else. You need an appointment to come see me.
Yes.
Like, that's just a message that goes out to several people that have tried to come into the clinic this week. Yeah, you need an appointment, please. But like I can go into Fred Meyer, Safeway, Rice's. I see you at Rice's a lot, and you just have access to the pharmacist. And so it's kind of cool. It's like MacGyver stuff. You got to be very versatile and ready. And I like that it's the things that the community really needs, but I can't wait 2 months to see my primary care for.
Well, and like I said earlier, by class, a lot of what I focus on or teach is over-the-counter drugs. And that's, very accessible. They're accessible in a lot of different places, but I think it's great if you can go to the pharmacy and talk to the pharmacist. If you're on other medications, what's the right medication for me? And sometimes if you're on other medicines, it may not be appropriate to take some of the over-the-counter drugs. But over the last 20 years, like a lot of drugs have gone from prescription to over-the-counter status. And there's a process for that to happen, but there's not anything that changes about the drug. When it goes from prescription to OTC, they recognize that it's probably safe and people can probably use it on their own to certain degrees based on certain restrictions sometimes. But I get a lot of questions, and I love talking about over-the-counter drugs. And, a lot of the allergy drugs, many of them were all prescription drugs 10, 20 years ago. And every year there's a couple of drugs that go from prescription to over-the-counter status. So it really is opening up, the ability of pharmacists to kind of help people with those things. Saves healthcare dollars, right? Because you don't have to go to the physician. You don't end up in the hospital perhaps for some reason. So there's a lot of benefits to that.
So reading between the lines, are you saying that if I'm like at the store and I'm looking at allergy medications or NSAIDs or whatever, I can grab that, head on up to the pharmacy counter, and the pharmacist is going to be willing to help give me some advice on how and what I should use?
Yes, they should.
Yeah. if they're not too busy,
if
right?
If they took Rob's class, then they should.
Yeah, because a lot of times you're just seeing technicians there, and the pharmacists are back there sweating, and
no, you should always ask. You can always ask and talk to the pharmacist. I'll tell you though, like I tell my students this. So when I used to manage a pharmacy, work in the pharmacy all the time, and a person would come in, they would ask a technician a question like that, like you just said. And they would say, well, let me get to the pharmacist. And they would say, oh, well, he looks really busy. Then I didn't like to hear that, right?
Yeah.
We're not doing our job right if we look so frazzled and frustrated that people don't want to bother us, because people are generally nice. And so I don't like to give that impression, right? And you mentioned I work at Rice's. I work part-time, and they do a really great job there. And
people love Rice's.
Because
it is community.
They're busy, but they've established a standard that if you come in, you can talk to the pharmacist. Right. That's the expectation. So that's what I think community pharmacy really should be. Right. That you have that expectation, even if they're busy, that you can do those things.
Okay, I'm going to start telling patients that. I'm going to tell them go to Rice's.
Well, anyway, I mean, they can always talk to the pharmacist. It's hard sometimes when they walk in. And there's a line, and there's a lot of people. And pharmacy in Oregon is actually really challenged right now. They have probably one of the, I think we're 49th out of 50 in like distribution of pharmacies around the state based on population. We have a lot of pharmacy deserts in Oregon. The only one lower, and I mean, they might not even be lower anymore. We might be 50. The only one lower than Oregon was Alaska.
Oh, geez, because sometimes you have to fly to the pharmacy. That makes sense.
So Oregon has had a lot of pharmacy closures. It's been in the news.
Why is that? Is there a couple of reasons?
For pharmacy closures? Well, I used to work at Weimar, and they closed all their pharmacies. A lot of it is related to reimbursements, right? I know you guys deal with the same thing, reimbursements and billing and those processes. And
pre-authorizations.
So and you mentioned earlier barriers, right? It does feel like a barrier sometimes. And we have to manage those things. But so it's limited reimbursements and the challenges, and there's, I won't get into all of it, but there was a lot of issues with billing, and there were these things called DIR fees that that caused for a while there, and that was actually one of the problems with Bimart, that they were getting these fees that were after the reimbursements already happened. So you already got your money, and then the payors would come like 6 months, a year later and say, you know what, you actually owe us more fees.
Boo.
And so it's hard to manage a business that way when you thought you had all this money. And then you didn't. So that's been a little bit improved,
Okay.
but reimbursements are still a big challenge. Drugs prices, I know with a previous guest, you talked about GLP-1s, and those are like $1,000.
Yeah.
Right?
Yeah.
So, here, in other countries, they're not so much.
No.
Yeah. So a small pharmacy, a small independent pharmacy especially, it's hard for them to stock $1,000 drugs, right? Put out $1,000 drugs, which are being dispensed quite a bit now. So you could easily have $50,000 in your fridge if you kept enough in stock all the time.
Right.
And then dispense those and maybe get reimbursed, if you're lucky, $5 or $10. And then you have to pay your wholesaler when you buy those, right? So you buy those from a wholesaler. Usually you have to pay those bills within a couple of weeks.
Yeah.
You may not get reimbursed from the insurance for a month.
Yeah.
So the cash flow is really, really hard. Unless you're a large corporation, you can handle that type of cash flow. It's hard. That's why it's hard for some places, small pharmacies especially, to carry some of these really expensive drugs.
Yeah.
And for pharmacies, that's not a high margin thing. Like not for the pharmacy.
No.
For the pharmaceutical company.
Yes, it is.
Margins are pretty
No,
good.
people
Very
often
good.
think that, you're getting a $800 drug, you think the pharmacy's making a lot of money. We are making less money.
Yeah.
You get your $10 drug, you may be making a little more money on that one.
Yeah.
Because it costs less,
Yes.
right? But you can't charge that much more over $1,000 because it already costs $1,000. So
No, definitely not.
The State of the Union.
So, can we talk about Big Pharma? Sure. Because when it comes to drugs, I'm a chiropractor, so I get people who they're definitely in their feels about the idea of drugs. And philosophically, I am not opposed to drugs. I think we're blessed to live in a time where people have so many options in terms of treatment, and there's therapies, and these things can change people's lives. But I guess the question I have is there a conspiracy by Big Pharma to take over the world, control people's minds, shut down all other healthcare, and, basically, buy up an entire side of the monopoly board?
are we whispering now?
Now we will speak in code.
Is this a hypothetical?
Yeah. I don't know. What's your take on that? Because
I think Big Pharma, right, it certainly deserves criticism and scrutiny for sure. They certainly do a lot of benefit, a lot of advances, a lot of new drugs. However, I think I don't like to blame any particular, because I think it's our system, right? Our system incentivizes drug companies to spend a lot of money to make a lot of money with new drugs. And so the incentive is to come out with drugs that are likely going to make money, right? So that's why they have what they call Me Too drugs. So you might have, so an example of blood pressure medicines are ACE inhibitors.
Okay. Yeah.
Lisinopril is an example. And there's a bunch of different ACE inhibitors. There's a bunch of different NSAIDs, right? And so why do we have so many of them? Yeah. Well, sometimes it's an improvement. Sometimes Big Pharma or drug companies know, well, those sell pretty good, so let's just make another one.
Okay.
Yeah.
So is that really...
Ours is green.
Yes.
Yeah.
Or they make a slight change to it. Or
Organic Tylenol.
Extra
exactly.
strength.
Gluten-free ibuprofen.
Right. Well, they just actually approved, you guys were talking earlier about someone taking like acetaminophen and ibuprofen, right?
Oh yeah, I had a patient today who told me before they came in, I took 3 ibuprofen and 2 Tylenol, and they did it for me. To make my job easier. It's like,
okay.
It's my job to poke a tender liver or no?
Well, they've approved so that you can buy ibuprofen acetaminophen combo. There's like a combo of that.
Oh.
They just approved an acetaminophen naproxen combo. Wow. And like most pharmacists look at that and be like, why?
Yeah.
Why would you do
Right.
that? And so
Because they'll sell.
because they sell, right?
Yeah.
Or they can promote it, right? And you see those things. What I talk a lot in my class, since it's OTC drugs, we talk a lot about, if there's any of my students listening, they'll be like, oh my gosh, he's talking about it again.
Yes.
Brand name extensions, right? So you go to the over-the-counter aisle and you look, I'm not picking on any of them, but you look at eye drops of Visine. There's a bunch of different products that say Visine with different ingredients.
Yeah.
But Visine is a recognized brand, so they really extended the brand to different ingredients.
Yeah.
Same thing with like Vicks, right? With cold medicine.
Yeah,
They'll say a lot of things. And so it's gotten really, again, it's a marketing thing, right? And so pharmacists focus not on those things. I always tell my students, don't you get distracted by the shiny box. You know the ingredients, right? You need to be able to look at the ingredients and know what those do and explain to the patient, this is what's going to work for you. And combination drugs, that's just, it gets tricky. Sometimes they're okay. Sometimes it makes sense. But sometimes it's just another way to add another product line, sort of. So,
yeah, so let's get into this because I know, for example, that people don't really know the difference between taking ibuprofen or taking Tylenol or taking naproxen. So, we deal with musculoskeletal issues. It's out of my scope to tell. I can't even tell people, to take an ibuprofen or take Tylenol. That's just not what we're supposed to do.
Chiropractors rule.
Yes,
I was
you
gonna
guys
say,
can. Yeah,
okay.
we can't.
Okay.
Technically, it's out of our scope. So, but I can explain to them, how each one works. So, from the expert, though, can you tell us the difference between, acetaminophen, which Tylenol is a brand name, ibuprofen, Advil is a brand name, and naproxen and Aleve is the brand name for that.
Yeah.
Yeah. So those are all over-the-counter examples. So the ibuprofen and naproxen we've used the term NSAIDs, non-steroidal anti-inflammatory drugs. And again, those used to be prescription. They're over-the-counter. Acetaminophen is not an anti-inflammatory, so it's just a pain reliever. So the big picture difference is acetaminophen or Tylenol helps for pain and it helps for fever. So those are the two main benefits, and it's really good. Right? It's really beneficial for those things.
Quick question though: is it true we don't know how it works?
Yeah, actually,
Really?
Right?
Kathy had asked me or had made some notes about how these things work, and I'm like, I'm gonna have to say on acetaminophen, they don't really know. They have some thoughts. So in general, NSAIDs work on inhibiting certain enzymes, which end up
COX-2 and COX-1.
Yeah, exactly. Yeah. So they inhibit those enzymes, and if you inhibit the COX-2 enzyme, it's anti-inflammatory, right? It reduces inflammation because that enzyme is induced on injury or things like that. Acetaminophen is centrally acting, and it
So like up in the brain.
In the
yeah,
brain. It
exactly.
acts on the brain, not
it
the
acts at
tissue.
pain transmission there, and it works on like variants of those COX enzymes, which sometimes they refer to as COX-3, but I don't.
That sounds made up.
Yep.
Well, I think it kind of is.
Yeah.
I read something recently that was like, does COX-3 really exist?
Yeah.
They don't really know for sure.
Right.
It's been around forever.
Yeah.
Right.
But
So it's an emerging field.
Yeah. They're not really 100% sure of the mechanism, but it does work for pain and fever. And then the NSAIDs work for pain and fever and then have an anti-inflammatory benefit, right? And even within the NSAID class, you mentioned naproxen and ibuprofen. They're non-selective COX inhibitors. They inhibit both COX-1 and COX-2.
Okay.
There are selective COX inhibitors, which have potential benefits, but also potential risks.
Yeah, those have traditionally
what's that?
had some bad ones, right? The selective COX inhibitors.
Yeah. So there was selective COX-2 inhibitors.
Yes.
Like what's a
Probably the most common one that people know is Celebrex or Celecoxib.
Oh yeah. Okay.
That's a selective COX-2 inhibitor.
Oh, I see. Yeah.
So the idea when those came out was if you inhibit COX-2 enzyme, which is the one that affects inflammation, that's good, right? You're going to have with inflammation. If COX-1 plays what they call like a housekeeping role.
Yeah.
It kind of helps with forming the gastric mucosa in your stomach, and
which neutralizes stomach acid so that you're not dragging stomach acid throughout the whole GI tract.
So like a good example there, if you take ibuprofen, it upsets your stomach, right?
Yeah.
Because it's actually not because it's directly irritating, but it's inhibiting COX-1, which is responsible for making that mucosa in your stomach. So that makes sense why it would have that effect. So if you make a selective COX-2 inhibitor that doesn't inhibit COX-1, you would think it's safer for your stomach, which it is. But then they saw, dang it, those also they are involved in making prostaglandins, and some of those are involved in blood platelet aggregation, which can cause blood clots. Long story short, the COX-2 inhibitors increase your risk of blood clots and stroke.
Whoops.
Yeah. So
I thought only chiropractors did that. No, it's the COX-2 inhibitors too. Crazy.
So I think what you were saying earlier, one of the first COX-2 was super selective. It was called Vioxx. And
that's the one.
Early 2000s, I think. Maybe late 90s. Anyway, it was recalled. It was pulled off the market because people were dying from strokes and heart attacks and things. So
yeah, big pharma.
Yeah.
Well, and that's the thing is,
well, there was, I think, some lawsuits because there was data suppression.
Yes, exactly, because they knew.
Yes.
They knew.
Yes.
And that is the thing, and it's really kind of a catch-22, that whole big pharma thing, because like you said, these drugs are incredibly expensive to make, and so it's like, why do they cost so much? Well, because it's literally billions of dollars that they spend. And it's some of it is because of our regulatory system and getting the FDA approval and everything. You got to show, all your homework, right? It's like you got to do the long division, and so they got to make that money back. And most drugs that actually get into those trials do not pass them. It's something like 1% of drugs that actually end up getting FDA approval. And so the whole process is incredibly expensive. And so it's like, I can imagine they're like, wow, we put a lot of money into this. And so, hey, a few deaths. Let's just, internal memo, none of our people should take this.
Yeah, there are definitely examples.
Except for Larry in accounting. Give him extra. Like, give him a gift basket.
But yeah, I mean, we could have a whole multiple episodes on.
I'm already thinking we got to get you back like 6 or 7 times.
Already.
Yeah. Oh, goodness. So let me ask you this. One of the things that I tell people that a pharmacist can be really helpful for is if people have concerns about polypharmacy. So this idea where you're taking too many medications or too many drugs. I know that I have I have some prescriptions, and whenever I go to a doctor's appointment, they read off a list of every drug that I've ever taken in my life.
Yes.
Yeah. It's like, no, let's update that. I'm only taking these 2.
Yes.
And they're like, oh, okay, cool. We got that updated. I go the next time, it's every drug again. And so, and sometimes when I go to the pharmacy, they're like, yeah, we've filled the prescription for this. I'm like, I haven't been on that for 3 years. And they're like, oh, good. But could you give it to me anyway? So one of the things I talk about with patients is that a pharmacist can be a useful advocate in terms of helping to navigate that because it's hard to keep it all straight. And part of the issue is information systems, not intent of providers or pharmacists or anything like that. So do you think I should be telling patients that? Is there something that you think people should know in terms of how a pharmacist could be helpful?
Yes. Do you guys have a soapbox I can stand on?
Yeah, you're sitting on it.
Oh, okay.
Yeah.
So it is super important that that you guys tell patients that you talk to your pharmacist about the medicines you're on. My soapbox comes from the challenge, and again, it's our system that has evolved where everybody agrees that you should get all your medicines in one spot so the pharmacist can review all those things and know what you're on. However, our system forces or encourages people to get medicines from different places, right? So you can go to Bryce's and get your medication, but then if you're in the military, maybe you have to get stuff from the VA sometimes.
Oh, yeah.
Because it's no cost if you get it from the VA. Now they have what they call specialty pharmacies. And so some drugs are sold or dispensed through a specialty pharmacy. So then you have to get some from there. I was just reading today, right? Some states are talking about importing drugs from Canada because it's cheaper in Canada. Because, well, that's a whole nother issue. But like our actual government is encouraging people to do that. I'm like, well, wait a minute, how can I do my job if you sometimes go to Canada or you go to a specialty pharmacy or even just Amazon pharmacy, you get some of your drugs there. You can't get them all there, right? You need an antibiotic. You need that now. You can't wait to get it mailed or sold later. And I don't know all the other things you're taking. So it's a challenge, and I think our system has made it more challenging to make it harder for the pharmacist to do their job. But you should still encourage people to check with their pharmacist. They should know who their pharmacist is. Right? When they go to the pharmacy, they should recognize them if they're on regular medicines, right? If you're never on a medicine, then you probably don't have a pharmacist. But
which
same
is
thing
okay
with you guys, right?
But eventually you get older.
And
you got to become good friends with your pharmacist.
Exactly.
And you want to be nice to your pharmacist because you don't want that guy to be like, I don't care if you get explosive diarrhea.
I'll tell you, I think one of the things that attracted me to community pharmacy was my first job as an intern when I was in school was at a little pharmacy in Silverton, Oregon.
Silverton's great.
Yeah,
I love
Pillbox
Silverton.
Pharmacy.
Yeah, okay. I've actually been there.
And actually Rice's is part of that Pillbox.
Yeah, I got a good friend that practices in Silverton.
Oh, okay.
Shout out Daniel Cote. Anyway,
that was my first experience in pharmacy, in community pharmacy specifically. And my preceptor was the pharmacist who oversees the students her name was Amber, and I still see her. She still works there, but she was so amazing that as a community pharmacist, right? She didn't just do a good job with the medications and all that, but when someone came in to get the pharmacy, she knew like they were the school bus driver, right? They did this for their job, or they had kids or whatever. So she would incorporate that knowledge about people into our counseling, right?
Oh, cool.
You need to be sure to tell this patient that this might make him drowsy because he drives the school bus. Right? So if you're an anonymous person, here's your drugs, I don't know anything about you, that's not the same as like, I know about who you are, I know what you do, I see you in the community. And so that's, I think, where a true community pharmacist can make an impact on healthcare.
No doubt about it. Yeah, I mean, personally, Rob has helped my family. My in-laws are 88, and imagine the drugs that they are on.
Good stuff.
And
we made sure that they moved here from Minnesota. We made sure that their pharmacy was at Rice's, and Rob has helped us explain things to them. Made sure things are going smoothly and that things didn't interact. Because they are on so many meds, because they see so many different doctors. The doctors are just they're just throwing meds at them. They don't know what the other doctor gave them. And so it's been huge.
Yeah, it's a big issue. And I think sometimes, Kathy, I don't know when you do intakes how much you go over people's medications, but a lot of times when patients are coming to a chiropractor or physical therapist, they just skip over the medications part, not understanding that there's a few medications that if you're on it, like it's gonna be important that I know, right? Like for example, like a fluoroquinolone, which will increase your chances of a tendon or connective tissue rupture, and so I don't want to be performing an upper cervical adjustment if you're on a fluoroquinolone, and so. The 4 or 5 people that are listening are like, what's a fluoroquinolone? And it's like, I don't even 100% know. Like, so a chiropractor's not a pharmacist, but, we get training in certain classes of drugs where it's like, you need to know. And then usually when that comes up and, or we're talking about blood thinners or things like that, the place I tell people to go is to the pharmacist. I used to tell them a long time ago, you need to go talk to your primary care, blah, 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 blah. And what I learned is that they should and definitely can talk to their primary care doctor. But the problem is the wait and the cost. A great shortcut is go talk to a pharmacist. And I've even had pharmacists who will pick up the phone. and they'll call doctors because I know enough pharmacists to know that sometimes when you guys are in the break room talking, you're talking about providers. And you're like, why are you prescribing this?
Yeah.
Like what is this dosage about? And a pharmacist is much better equipped to have some of those conversations than a patient is. And it can be very intimidating because I know they make those words long on purpose.
Yeah, they do.
Right? It's impossible I couldn't spell fluoroquinolone. I can. But, it's like,
I'm impressed you can pronounce it.
a lot of practice. So.
Well, Kathy's helped me in my class before, and I don't know if you remember, one of our cases was someone who'd been on a fluoroquinolone and was having a tendon injury and stuff. So I think it's so important to have that familiarity and know, kind of refer back and forth. And your presence in my class has always been super helpful because our students come away from your lecture knowing like, oh, I can refer them to the physical therapist, right? Because I think what I also talk about with our students is, like, we know what we know, but we also know when we need to send them somewhere else.
Yeah.
Right? I think that's a really important job a community pharmacist does, is when someone comes in and says, what can I get over the counter for this? I'm like, nothing. You need to see somebody. Right?
Capital.
Now.
And maybe it seems like we're like passing the buck, but like, no, actually, that is a super helpful thing I tell students is if you can recognize that is an emergency situation or an important situation that they need to see someone else about, that helps everyone. It helps the provider, right? It helps the healthcare system. And they're not wasting their time on like trying to treat something over the counter when they really shouldn't be.
Yeah, you get them that pneumonia vaccine, you get them to the hospital right away. So, what's your favorite drug, Rob?
Ondansetron.
What is that?
Just because I like to say it.
Yeah.
And actually,
It sounds fun.
it's for nausea.
Okay.
Yeah, and but when I was a student at Salem, I did my rotation at Salem Hospital. It was brand new, and I had to do an in-service for the nurses on Ondansetron and so forth.
Ondansetron.
That's what I heard in my head.
But anyway, it's a fun word to say.
Yeah. Oh, man. So
I just want to take that just because
I know. Hey, you want to do some Ondansetron?
Yeah, let's go.
Okay. So can you talk to me about the medicine cabinet? I told you a little bit about a patient who I had come in, and they told me that they were taking a medication. I was like, oh, so you've been working with your healthcare? They're like, no, I just had some, right? I will admit that, I go to Mexico like once or twice a year. I enjoy visiting La Farmacia. And actually, the one that I visit, the lady there, her name is Maria. So I see Maria at La Farmacia. And so that idea of people kind of working their own home pharmacy, give us some pointers. Like, is that harmless? Is it harmful? Like, what do people need to hear?
Well, first of all, if you say La Farmacia, they won't know you're from the U.S.
Oh, really?
You're local, so say La Farmacia.
So I might get better prices.
Yeah, if you say La Farmacia, they know you're like not from
Farmacia. Okay, gotcha.
Anyway, no, yeah. So that's actually a good example, right? I say people get medicines from all over the place. And sometimes it's from Mexico, and
we call them spicy antibiotics.
Oh my goodness!
Yeah.
There's a little bit of tahini in there. Yeah, it's delicious.
Well, and I'm not discouraging that, but people should be on medicines and prescription medicines are a prescription for a reason.
Yeah,
many of them need to be supervised or monitored or whatever. And so it's important that someone know, right, that why would they were diagnosed or prescribed that in the first place. If they're getting them from Mexico, it's less expensive, right? I know people who live in Arizona and they cross the border because that's the only way they can afford their medicines. And again, that's our problem with our system. However, there is a problem with counterfeit drugs.
Yes.
So and people are like, well, it looks just like the drugs I got in the U.S., but
it's the same.
Yeah.
Counterfeit drugs are like amazing about how good they are at making those. I was on the board of pharmacy for 8 years in Oregon, and we actually had a speaker come. That was his job, actually. They helped kind of find online drug sellers who had counterfeit drugs. And he was telling us, he's like, you know what? Even drugs from Canada, that's actually a big route where Eastern European countries that make counterfeit drugs ship them through Canada because they know people in the U.S. will import them. And so even if they look the same, you're never really 100% sure. One of the things I advocate for about pharmacy in the U.S. and community pharmacy is that we have a safe drug distribution system, right? It is monitored, it is regulated, and it is, you can be pretty sure your drugs are safe and they are what they are.
Yeah.
That being said, if people are going to Mexico or even Canada to get drugs because it's the only way they can afford them, I would just encourage people to do as much research as you can to see, are they legitimate? Are they have good reputation? That type of thing.
Don't buy them off of a cart.
Yeah.
No.
I mean, kind of.
Yeah.
Really do the best you can to kind of monitor that. But, and there are the drugs, probably most of the drugs there are legitimate, and they're just less expensive because they're less expensive for other reasons. But
last time we were down there, we were in Cabo, and Mandy and I were standing. We were waiting for our kids to come back from some horseback riding thing, right? We're standing there. These two guys walk by, and we wave, and they walk by. They walk to the next couple people that are sitting there, and they're like, "Hey, you guys want some ecstasy or cocaine?" And I was like, "Mandy, what is wrong with us that we don't look like we would enjoy some nice party pharmaceuticals?" Yeah. I was like, I know Maria. So, oh gosh. But I guess one more question that I would have is kind of on that same vein, and fentanyl, right? Which that's such scary stuff. I know people in this community who have died from fentanyl overdose who did not know that they were taking fentanyl. So, as a pharmacist, what kind of advice would you give maybe people who are out there doing more recreational pharmacy whenever it comes to some of those risks?
Well, for one thing, we talked earlier about naloxone, right? That's why the board and other regulators have, or boards, I guess, want naloxone available because that's what happens. The street drugs get laced with fentanyl because it's so potent. You only need a tiny, microgram
my gosh.
to lace it, but it's so potentially dangerous.
And so the naloxone is Narcan. That's
counteracts that. Unfortunately, there have been other designer drugs that are not counteracted by Narcan. So that's a problem. So anyway, yes. Be as safe as possible. Try to have naloxone around, and it's a problem. I mean, it is a real problem.
Yeah.
Across the board, the Board of Pharmacy has tried what they do to regulate those things, but it's just a real challenge.
Okay, tell us about a time when you caught something as a pharmacist that actually prevented potential serious issues for a patient.
Give us your hero moment.
Yeah, let's see.
Actually, I'll stick with fentanyl.
Okay.
So
fentanyl for $500.
Fentanyl. This was years ago, but so fentanyl comes in patches, and it's a great pain reliever. It's super potent, very, very, very potent, and it's really indicated for cancer pain, end of life pain, that type of thing. It's not being used. I don't see it as much anymore, but it's still an option. But it comes in patches and lozenges that can get absorbed through the mouth in different ways. Anyway, most people who are prescribed fentanyl, you cannot be opioid naive if you get prescribed fentanyl because it's so powerful. Which means you have to have been on an opioid already. Right? Because if your first exposure to an opioid is fentanyl, you probably get respiratory depression and you could die because it's just so strong.
Wow.
But if you've already been on oxycodone or hydrocodone and it's just not, meeting the pain relief, and then they put you on fentanyl, that's okay.
Right.
Because you've already been exposed to it.
Yeah.
Anyway, I had an older patient. It was kind of during the whole opioid crisis, which was a whole nother story. But and someone was prescribed these Duragesic patches, which is the fentanyl patches, and they were still relatively new. It says right on the box, don't give it to someone who's opioid naive.
Yeah.
And we had a prescription, and it was 80-year-old lady, and I asked her what other pain medicines they've been taking, and she said none. And I was like,
well, you're not taking these.
Are you sure?
Yeah.
So, and you guys know sometimes people say no.
Right.
Yeah. They lie all the time.
Yeah. But anyway, we called the doctor and we're like, well, we're not really sure. You're not questioning it, but just want to check and see. And then they ended up changing it because they were like, oh, okay. So anyway, who knows what would have happened, but potentially an issue.
Yeah. Good catch.
Over the counter.
There's people don't even know why that would be dangerous unless they know why that would be dangerous.
Right.
Yeah,
Yeah.
exactly.
Yes.
Yeah.
Wow.
Scary thing.
Yeah.
Well, and then sometimes the other thing that happens is like, my friend took this and it worked great. Right? I have some of these.
Don't take your friend's drugs.
No.
Yeah.
An example there was had someone ask about a laxative over the counter because someone said, oh, this worked great for me. Can we use this for my parent? Right. And I said, well, so over the counter, right, we have laxatives. But there's like 8 different classes of laxatives when you say laxatives. There's different kinds. And so the laxative that they were asking about was like, yeah, that would work as a laxative, but it's also going to cause significant fluid loss, electrolyte disturbances. And someone,
we've seen the commercials.
Exactly. So, but in someone who's on heart medicines, that's really dangerous.
Yeah.
So they would need a different type of laxative.
Sure.
So not all laxatives are the same, right? So it really depends. So what worked for one person maybe is not appropriate for somebody else.
Yeah. Man, Kathy, I'm glad we're finally talking about laxatives on this show.
Oh, I love talking about laxatives.
Yeah.
It's like my favorite class of the year.
Again, we got to have you back to a whole episode on just laxatives.
Yeah.
Oh, can I tell you what I do in class for laxatives?
Please tell me what you do in class.
So, like I said, maybe it's 7 different classes of laxatives, right? Stimulants, saline laxatives, osmotic laxatives, hyperosmotic. So they're all, and stool softeners. And so, anyway, me and my coworker who used to teach the class with me, we were like, how do we cover all these? Yeah. So we do speed dating with laxatives. So we assign, like, you're a student. I say, okay, this is your laxative, Kathy. You are Miralax. You need to learn all about Miralax. And then Raul's going to be my patient, and he has a patient profile, and he could be like, I haven't had a bowel movement for a couple of days. And so I have like 6 patients, and then maybe 15 laxatives, and they go around the room and they meet each laxatives meet each patient for like 3-minute speed date. And they need to learn all about each other in those 3 minutes. And at the end, they'll say, okay, go find your perfect match. And so you might go find Raul's my perfect match. I'm the best laxative for him.
Yeah.
And then there's always a few laxatives that are like, they go into the lonely laxatives club because they don't really match with anybody.
Oh
Castor
my God.
oil.
I bet you nobody forgets that.
Oh, no, they love that.
This is why Rob wins the award.
I guess so. Yeah.
Yeah. So that's my laxative.
I can imagine somebody filling out the paperwork to nominate you. And like, what does he do? The special laxative dating?
Yeah.
Speed laxative dating.
Speed laxative dating.
But I mean, laxatives can be so dangerous. Like,
They are,
they
actually.
literally should be probably locked up.
Yeah.
Like they should be behind the counter, but you don't need a prescription for it.
There was a saline laxative a few years ago that got removed from the market because it needed to be diluted. It was a saline laxative, one of the Fleet products.
Okay.
Saline laxative, but you had to dilute it.
Yeah.
And if you didn't dilute it, it was super dangerous.
Yeah, there you go.
How often do people read instructions?
Never.
Never. Well,
never.
In all fairness,
Yes.
they give you like the
Yes,
instruction
that's
things.
true.
You like fold it out. It looks like a map of the continental
Yes.
United States.
And I'm not blaming the people.
Yeah.
Because, right. It was the packaging, the way
Yeah.
it was
And it's in
processed.
9 languages. And
Yeah.
it's like, I don't want to figure out how many of these I speak. Probably none.
Yeah. So
Yeah.
people were like being harmed.
Yeah.
And so it got removed from the market.
Goodness.
From that.
Yeah.
for that
Or
reason.
X-Lax, remember that? Child of the 80s, you know, it's like, hey,
Gotta
you can put
lose
that in
weight.
anything with chocolate.
Oh, yeah.
Yeah.
Yeah, great prank. Great prank. It's like,
Well, that
yes.
one
why would you make a laxative that looks like chocolate?
and that original, I'm getting into my history because I'm in the history of pharmacy too.
Yeah.
That original laxative was phenolphthalein, which they ended up finding could be cancerous.
Oh, dang it.
So that's not, it's not
Yeah.
the same ingredient anymore.
Man, these bowel movements were smooth.
Yeah.
But
Yeah.
I got cancer.
Yeah.
Bad news. Yeah.
Pros, cons,
Yeah. Good news, bad news.
risk, benefit.
Oh my goodness. Well, I think it's time for a game.
It is. Can't wait.
Game time. Oh, I should open the. We were getting ready and we had our laptops out, and Rob's like, "Do I get a laptop?" So I figured I either have to buy him a MacBook real quick, or I'll just shut mine. So here we go. Now it's all fired up. I gave you an option between a couple games, and I'm not going to surprise you. We're going to go with the one
Either one's fit.
that you chose here. We're going to be talking about some pharmacy rules. We're calling this game Statute or Sham, okay?
Mhm.
And so what I'm going to do is I'm going to read you a rule, may or may not be a real rule. And I mean that on a few levels. So it might be like a real rule, might be a fake rule, might be that the AI did not do a good job of researching. So all I can guarantee is a good time.
Okay.
Okay. All right. And you just tell us, is this a real rule or not? Let's start right here at home. Okay.
Mhm.
So this is going to be an easy one for you. All right. Oregon made pseudoephedrine prescription only in 2006, then repealed it in 2021, leaving Mississippi as the only holdout. Is that statute or sham?
It's statute.
That is statute. See, I said it's
He's
gonna be
an
easy one.
expert.
Yeah, he's an expert, right? Okay, we just need
We
to
can have a
identify
whole
you as
show
an
on
expert.
just
Okay.
Sudafed.
Okay.
Right. How about this one? In Alabama, a drive-through window may not be the only means of access to a pharmacy counter. Is that statute or sham?
I'm not really sure I understand, but I'm gonna say statute.
That is a sham.
Oh.
Yeah. So I didn't even know they had drugs in Alabama. Yeah.
I have to say,
Legal.
actually, I don't know about Alabama,
Uh-huh.
but I mentioned earlier about Oregon not
Yeah.
being that great as
Mhm.
far as pharmacy. Some of the, I know pharmacists from Arkansas and some of those states, they are actually leading the way
Yeah.
in PBM reform and reimbursement
Okay,
reform.
let's
Really?
They are
go.
way stronger in those areas than Oregon is. And so,
Let's go,
Okay.
Arkansas.
yeah.
Well, can I take you to Louisiana then?
Yeah.
All right. Louisiana dispenses medical marijuana through licensed pharmacies, not dispensaries. Is that true or false?
Connecticut does through pharmacies. I don't think Louisiana does, but I'm not sure.
Louisiana does.
Oh,
They
Connecticut was the
do.
first.
Okay.
Connecticut. Oh, yeah. And actually, that was the next one on here. Connecticut requires medical marijuana dispensary facilities to be run by a licensed pharmacist.
Oh, yeah.
Wow.
We're going to give you credit.
Okay.
Yeah, we're going to give you credit
Mm-hmm.
for that. That was very good. Yeah. You see that, Terry? Your man's getting it done here.
That's right.
All right. How about this one? In Utah, they require a pharmacist to be physically present within 50 feet of the dispensing counter at all times.
I'm going to say that's true statute.
That is fake, but that's kind of a tricky one because they do have a number. I just don't think it's 50 feet.
Well,
Wow.
Oregon kind of does.
Yeah.
What's Oregon?
I mean, it's not a number. I mean, it's not a number, but like the Board of Pharmacy, when I was on the board, the rule was if you were on the sidewalk in front of the pharmacy, you're good. But you step off the sidewalk,
Yeah.
you're too far.
oh.
Like in Oregon has rules for like chiropractic assistants, right? So you
Oh,
can be
really?
helping
Yes.
out. And
Yeah.
so if I have a chiropractic assistant working for me, I have to be within the same contiguous space.
Oh.
Google the word contiguous.
Yes. It's vague, yeah.
Yeah,
So,
but the idea is you got to be accessible
Yeah.
and not via text message or
Mhm.
phone, but like able
Mhm.
to show up so that you can help move a body.
Mhm.
So
Did you say hi to body or just move it?
my lawyer said that I can't answer. that.
Okay.
All right, couple more here. So some states set a hard pharmacist to technician ratio. Others set none at all. Is that true or is that false? Or is there like a standard across all pharmacy?
It's true. Yeah, some states have a ratios, others don't. Oregon used to have a ratio.
Mm-hmm.
It was 1-to-1, then 2-to-1, and they got rid of it. But I'm not sure which. I think Washington, D.C. still has hardcore ratios, and a few others do. Yeah.
Well, you nailed that one. How about this? Automated dispensing kiosks that hand out prescriptions without a pharmacist on site are legal in some states. Is that true or false?
Oregon actually is just approved some of that. And so for rural areas where there's pharmacy deserts, that they have dispensing kiosks that have a video where you still have to be able to talk to the pharmacist, interact with the pharmacist. And there are other ones, I don't know if they have that video requirement, other states, but yes, there are.
So it's like the drug red box.
Yeah.
Yeah, kind of.
Why not?
Hey, honey, what would you like to take tonight? Yeah.
But I think Oregon...
What was it? I'm a disco techian. What was that nausea drug?
Ondansetron.
The ondansetron. Yeah. So you want some of that? Oh, it looks like they're all out.
Shoot.
Yeah. I keep hitting B6 and it won't. Yeah.
Well, Oregon has so there's some pharmacies. There's a family of pharmacists called, they own Murray Drugs in Heppner and I don't know all the states there, or all the cities there in Central Oregon. They have 3 or 4 pharmacies. Their entire, 2 of their kids went to pharmacy school, so I knew them. The parents are pharmacists. Anyway, they had to do some of the first cabinets, mostly because there are people who drive 100 miles or more to go to the pharmacy.
You've got to be kidding me.
And so they have cabinets that will go, for example, in a clinic that is closer, that they go stock, and then people can pick them up there, but still talk to the pharmacist.
Okay.
Yeah, so it's mostly for rural areas that you'll see that.
Interesting. Man, okay. Well, this guy seems like a real expert.
I think he knows what he's talking about.
All right, Kathy.
Yeah.
Takeaways.
My takeaway. This is always...
Always a surprise, I know.
Always.
I know. Wait till episode 100.
Oh,
wait.
Wait, I got it this time. I got it. My takeaway is the pharmacist is a know-it-all.
It is. They should be.
Mm-hmm.
They better be.
Yeah. They definitely are. They're lifesavers. And I Rob asks me, and I'm always happy to do it too, to come in and talk to his students. And I tell them that, they're gonna graduate with a doctorate, and they may not even know it, but they're gonna save lives. They're not physicians, but they might, as Rob talked about, tell a patient, you can't take these meds, or call the doctor, and they may have saved a life and they don't even know it. So, the pharmacist is your friend.
Absolutely. Mm-hmm. My takeaway is that laxatives are great for dating. Yeah, it just enhances dates in every single way. I think that's what you were saying. Yeah. So take a good laxative before you go out on the town for the night. I think that's probably the chiropractor wisdom instead of pharmacist wisdom. But no, Rob, you're awesome. Yes. And seriously, I think it would be great to have you back on sometime.
There's so much we didn't cover.
Yeah, I'll tell you, we didn't invite Terry back.
I'm not laughing.
Just kidding, Terry.
I'm not laughing.
You're definitely welcome.
That's terrible.
That was a bad joke.
Do not say that.
Naughty joke. No, we love you, Terry. And but thank you so much for sharing your wisdom. Great. And hopefully, people go. You know what? Just go out there. Find out your pharmacist's first name. Yeah. I know my pharmacist's first name. Yeah. I don't want to call him out here, but they wear name tags. You don't even have to ask, Call them by name, your good community pharmacist. And so
say thank you.
Absolutely. Right. And they want to talk about drugs, not just side effects, right? They want to talk about drugs.
Yeah. Yeah. And laxatives.
And laxatives mostly, right? And I think there's just one important piece of wisdom that we have left to share, and that's there's no I in pitch.